Hi, my name is Charlotte Conway, and here's my James Scholar project for the class HK 208 for medical ethics. And the case I'll be presenting is Leo Oldsick, who is from Long Island, and the case is regarding palliative medicine and its impact. In the year of 2009, Oldsick and his wife were in a very stable relationship. They had two children and they had little to no arguments occurring within their household. And his wife constantly took care of Oldsick and occasionally his son because he had dementia at 88 years old, as well as heart failure and kidney issues. But eventually it became too overwhelming for his family to take care of him. And they had to install a railing to prevent Oldsick from jumping outside of his bed. So, as he was struggling at home and becoming very distressed, they brought him to a hospital nearby called Franklin Hospital. So, originally, when he was admitted to the hospital, specifically into hospice, he was not calming down for about 3 days. And this was really hard for his family to see him act this way, even when he was in an assisted care setting and had constant care from doctors at the hospital. The doctors even tried a few medications, but it did not calm Oldsick down. So eventually, the doctors moved on to putting him on an IV drip, which can be described as palliative medicine. And this was supposed to help his constant pain and shortness of breath. But what was really in the IV bag was a few different types of medications, such as Ativan, a brand name of lorazepam, and he was given Roxanol, which is a liquid morphine. And if you know anything about morphine, it's supposed to help with pain, but it can be a slippery slope, and we'll get into that later when using morphine for patients. But it's known as a common method of palliative medicine to use to make patients ultimately more comfortable. And as he became more comfortable in hospice, he was sleeping very soundly. He was not but in distress, but his blood pressure continued to drop. And this showed that his IV drip was making him really relaxed and almost too sleepy, but ultimately his suffering was reduced greatly. Um, and this is where ethics come into question because as his blood pressure was dropping and he was not very responsive, his family was needed to decide what further steps they wanted to take, whether they wanted to keep him in this condition, whether they wanted to stop the IV drip, but then he might be even in more go back to being in distress. So they had a discussion at the hospital with the doctor, and during the discussion, his daughter ultimately said they wanted Oldsick to go peacefully, and gave the doctors permission to continue sedating Mr. Oldsick with the IV drip. And Mrs. Oldsick, his wife, decided that nutrition and water would not be necessary for him, even though he could not feed himself, because his body didn't necessarily need it. And if they were to give him more food and water, this could just feed the dementia in his brain ultimately. So after 2 days since the meeting, and Oldsick was still on the IV drip, he passed away. So Mrs. Oldsick stated that she did wish she could have said goodbye to him, but was told if they had taken him off the IV drip, he would have likely woken up and been more agitated and angry. But one of her regrets was not being able to say goodbye to him. And when the doctor was asked by reporters how he would describe Oldsick's case, he said he would describe it as terminal sedation, which ultimately means comfort care. And some families can't really accept that. So he believes that as a doctor, if the patients are ill, the least he could do is provide them with comfort. And that's what he ultimately did in the situation. So regarding the biomedical ethical implications of Olczyk's case, there were no court rulings involved in this case. But an article by S. So and their colleagues in 2016 states that they believe continuous sedation until death is ultimately equivalent to physician-assisted suicide, that we learned in class, which is obviously a patient taking his or her own life with the aid of a physician. But in this article, they equated these concepts to be the same because when a person is sedated, they're ultimately losing their quote personhood, um, and their lack of social interaction because they're unconscious due to the drugs. But PAS is not a constitutional right according to the Supreme Court, and each state can decide whether they believe physician-assisted suicide is legal or not. So this just shows how it's ultimately up to each state whether they believe this is right or not for patients to do, but many doctors still do it otherwise. And this is ultimately up in the air issue and can be described as a slippery slope for patients, doctors, and families, as they're all stakeholders in this situation. Specifically, the biomedical ethical implications regarding this case has to do with making Mr. Olczyk comfortable. And since that was the goal of bringing him to the hospital and putting him in hospice, um, that is what the doctor was trying to do, was ultimately to make him more comfortable. But from the family side, they could perceive it as, did the doctor know that this would happen by attaching him to an IV drip? Or did Dr. Hallbridge not know that this would eventually happen? So that's some of the implications of this case. And even after this case, there's ultimately still a debate regarding if palliative medicine should be allowed to keep the patient comfortable, or if the doctors must clearly tell the family going into these types of situations that it's possible you may lose your loved one if we put them on this medication. And I think that's interesting to point out both sides of the case and how different families have different perspectives as well as doctors. And here's my references, and that's all. Thank you for listening.